All right. There is different classifications as far as credentials beyond your RRT or CRT exam. The CPFT is again an entry level, where the advanced level would be the RPFT. CPFT, really little bit of review, and you could sit for that without too much difficulty. You know enough. We teach you enough to get through that. RPFT is a little bit of a different story, and really almost have to work in a diagnostic lab to have the exposure to all the different things that they are talking about. Just as an aside, the NBRC has just come out with their advanced critical care specialist exam, and people I have talked to who have taken it, who've been in the field for 15, 20 years, have said, wow, that was hard. Because they talk about things that you in your institution, you may have worked in the ICU for 20 years, but do you do nitric? Do you do high frequency? Do you do ECMO? And that's what they're looking at. And unless you're working in an environment where you're seeing all that stuff, it's a tough exam. The RPFT is kind of like that too when they start talking about blood gas quality assurance, when they start talking about things like pulmonary stress testing, something again which we don't often see, but we'll talk about as we go along. Why do we do pulmonary functions? Again, it's to look for the presence of lung disease, and classifying it as whether it's normal, obstructive, or restrictive, and then classifying it as whether or not there's a diffusion defect. ATS does recommend anyone 45 years and older who has a history of smoking or with symptoms should have a PFT done. We also want to quantify the severity. One of the things, if you remember back to the gold standard, we looked at taking FEV1 and looking at what percentage it was of normal to put it into a category as far as mild, moderate, severe, very severe. And then also taking a look at is what we're doing working? Is the medication we're prescribing making a difference over time? So serially following pulmonary function tests. There's a big, anytime there's an environmental exposure where there's perhaps a chlorine, train carrying chlorine falls off the tracks and leaks chlorine into the atmosphere, they'll do testing serially of people in the environment to make sure that they don't have long-term exposure and a need for some further intervention. Pre-op, we'll go ahead and take a look at surgical patients to see if they're at risk, especially thoracic or upper abdominal. And then disability testing is a whole separate ball of wax, and the attainment of a disability, that's what I'm looking for, disability award is a very prolonged process. In like I say, legal disability, it's a whole different set of calibration you need to do, as well as how you report the data. And same is true with the military, as far as I'm going to date myself, Agent Orange exposure, but also looking at the folks who were in Kuwait and in Iraq and all the problems they had secondary to exposure to various agents that didn't seem quite to follow the normal process there. Remembering it doesn't diagnose necessarily a specific disease, it puts it into a category, and within that category then using our other patient assessment and diagnostic and laboratory data and other stuff, we can go ahead and actually pick up a disease. We know that PFT predicteds are based upon age, gender, and height. There is various tables now for different ethnicities. Weight, again, has no direct influence on the predicteds. It will, however, affect their pulmonary function and present a restrictive-like picture in the morbidly obese. We know that these values come from different regression equations. If you're really a geek, you want to go look at them. They're in Egan. Yeah. The adult, some of the more common ones are Morris, Crapo, and Knudsen. Crapo was the one that was utilizing primarily Mormon population. And in pediatrics, there's a couple of them that are there also, Sue and Polgar. Not that you need to know those names. They don't really make it matter or anything. We normally consider 80 to 120%. That's what we've learned as being the normal value, with the exception of being the FE1 to FEC ratio greater than 70 being considered normal. ATS prefers to use the 5th percentile, the lower limits of normal, which is basically a 95% confidence interval. Again, getting back to our highly technical things. We would rather have somebody who doesn't have the disease but is right at the border be classified as having the disease than have somebody who does have disease slip through the cracks. So we're going to use and say 95%, that lower limits of normal are 95% of the normal people. The bottom 5% might get called as saying that they have a defect of some kind. But those folks that truly do have the defect will always be caught. So we're going to have false positives, but it's better than having a false negative. Okay. Anyway, that's what the ATS says. Just back review time, 4 volumes, 4 capacities. The 4 volumes make up, 2 or more of the 4 volumes make up the 4 capacities that are involved there, and I don't think that should be anything too far from where you're at. It's a nice picture. We know that the RV and all of the things that make up, or that RV is in the process of making up, cannot be directly measured. There's really 4 methods to determine it, 3 of which we've talked about previously. The helium dilution being a closed circuit, nitrogen washout being an open circuit. Body plethysmography does not truly measure FRC. What it measures is something called thoracic gas volume. It's measuring the gas within the thorax. Body plethysmography is more accurate than the other 2 because in the face of a total airway collapse, closed circuit helium dilution, open circuit nitrogen washout where we're washing it out with 100% oxygen, in the face of a complete obstruction, they'll never get there. The helium will never equilibrate. The oxygen will never flush that nitrogen out because it's a collapsed area of the lung. Body plethysmography will pick up on that because it's looking at the thoracic volume. Okay, so in most people, those 2 values should be equal. However, thoracic gas volume is something that's a little more accurate in the face of somebody who's got severe airway obstruction. And there is another way to measure total lung capacity looking at the chest x-ray, and just understand that there's an additional way that you could do that. I'm not going to get into what the planimeter and ellipse methods are. It's beyond where we're at because we're not reading chest x-rays in this fashion. But there is a way that you can, looking at a PA and looking at a lateral, actually reconstruct what the size is. Key points, remember that the closed circuit, open circuit, and body plethysmography are all done at the end of a normal exhalation, which in theory should be the FRC. And usually these are not effort dependent and highly reproducible, and they're just easy studies to end up doing. Remember, helium dilution requires that the patient rebreathe this gas. It's an inert gas, but it does have the process through the rebreathing of that helium concentration that I need to do 2 things. I need to scrub the CO2 out, and I need to add oxygen to the system. I don't have that one up there, but that should be up there. Oh, there it is. Oxygen is added to the spirometer. And there's this fancy formula you can utilize to be able to determine what the FRC is for our purposes. I don't care that you know how to calculate it. If you ever decide you want to go back and take the CPFT, then you can go ahead and learn it. The only other thing that I want you to understand is that this analyzer that is used is a Wheatstone Bridge using thermal conductivity. What the hell is that? It looks like this. And just remember Wheatstone Bridge. That's enough. It's the way the helium alters the resistance within a circuitry. And you'll never need to know more than that. Just again, the system what we end up having. At FRC, so at the end of a normal exhalation, I open this valve, and now what they're able to do is breathe in this heliox mixture, or helium mixture. Then as they exhale, it goes through the soda line, which is used to remove CO2. And then it goes and passes through a helium analyzer, and we're watching the helium concentration involved. And just remember, we know that there's 0 helium to start with, and maybe there's a 10% helium here. And as they equilibrate, we end up having a final helium concentration that's equal between the two. And using that formula, you can go ahead and calculate out. And this is kind of just an example. Helium percent, I won't expect you to do this. Helium percentage initially of 10, final of 6. The volume in the spirometer was 3 liters, so I need to see how much of that was depleted, and we found out that our helium, our FRC, was actually 2 liters. Now again, this needs to be corrected from ATPS to BTPS. I'm measuring at ambient temperature. I want to know what it is inside the person. Somebody remember how to end up doing that? ATPS to BTPS? There's a chart. Yeah, it makes it really easy. If you take a look at what the patient's or what the environmental temperature is, it's that one that has a water vapor and milligrams per liter of water content. Final column is ATPS to BTPS. It's a very easy conversion to end up doing. From that FRC measurement, then, we can subtract off the ERV that we got from the spirometry. Now I have my RV, and I can go ahead and determine TLC. Key fact, put a star by this one. No leaks. Mouth tightly wrapped around the mouthpiece, which is awful disgusting when you pull it off and you got all this drool that keeps. Here's a box of Kleenex. Before you take it off, here, take the mouth off. Eardrum puncture, that's an open connection. So you'll get errors there. Okay. Leaks in the equipment. So leaks are bad for helium dilution because I'm not allowing for that equilibration to happen. Some of that helium's leaking out into the atmosphere. It's a closed system. Nitrogen washout is basically where I'm breathing 100% oxygen. Again, that switchover has to occur at FRC. And then we allow them to breathe 100% oxygen until the nitrogen concentration goes down to about 1%. Normally it's done within a few minutes. COPD patients, again, might take a little bit longer. There's no rebreathing, so there's no worry about CO2 scrubbing or having to re-add oxygen. And there's the fancy formula for what you would use to derive the FRC, the volume that you've collected over time, what the end concentration is divided by the 0.78. Okay. Again, this is the system that we end up having at FRC. I flip this valve and I now breathe in 100% oxygen and exhale into my spirometer, and I watch the percentage of nitrogen wind down. Yes.
Will we be doing an equation?
Only you. No. No equations. Body plethysmography, again, is a little bit different because it's measuring not only the thoracic gas volume, but it also measures the airway resistance, which is probably the more important, I don't want to say the more important of two, but certainly gets a lot of data on there. And it's basically where a patient breathes normally, and at this FRC, we lock them out, and we ask them to pant at about a cycle a second, like a dog, with the glottis open. And it's a real complex mechanism. One thing you want to do is have them hold their cheeks, because the puffing of the cheeks will actually give you inaccurate readings as far as that when you're doing that panting mechanism. So here she is sitting inside there, and she's watching, or she's panting, and we're watching these oscilloscopes, and what goes on with them is really more than you need to know. But remembering that it's Boyle's law, if I know what the pressure at the mouth is, what the pressure in the box is, if If I know what the volume of the box is, I can determine what the volume inside her chest is. And it's just a relationship that is being created. And I'm not going to go into that. Don't even worry about it. And this is just talking about the pressure volume change. This is the important one I want you to follow. Thoracic gas volume. It's the amount of volume that's inside that thorax, even when there's an obstruction present. And it's just a derivation of Boyle's law. So those are lung volumes. Airflow measurements is basically where we want to be able to see if there's any loss of air, patency of the airway due to airway collapse, how severe any airway impairment is, and other things related to our airways. Yes, Katie?
Did you just say the amount of gas present even when what's present?
Obstruction. Okay, I'm sorry. I'll stop then. If you look at most PF labs, they do body box. They don't do helium dilution or nitrogen washout. Ryan, did you have a body box?
No, the patient gave me it, so
How rude. He's a voyeur. We good? No? Yeah? Maple guy?
So right, total gas volume is that
Thoracic gas volume.
thoracic gas volume?
Yes, that's what TGV stands for.
About the same as your FS?
Under normal conditions. But people who have very obstructed airways, who don't have contact, and okay, hold on here. Here's my chest, right? Let's say I have a bronchus here where it's collapsed. All this gas distal to it would never come in contact with helium, would never come in contact with oxygen to wash out the nitrogen. So the FRC would be a lower measurement than we would otherwise have. This captures everything, the entire volume of the thorax. And therefore, it's a little bit more of an accurate reading in the face of patients who have obstructive airways, which we encounter once in a while. That was a joke. If you remember the forced vital capacity, amount of gas that can be exhaled after a forceful exhalation, after a maximum inspiration, and from that we can derive our various values, FEV1, FEV3. ATS recommends at least 6 seconds of duration. And in most normal, healthy people, that's actually kind of hard to attain because you got to really push them to keep pushing out gas because they've already emptied it all. 200, 1200 is basically the very initial portion, good index of large airways. 2575, good index of medium-sized airways. That's the middle 50% of the vital capacity. If I were to, get a picture of it? No. If I were to look at my flow volume loop, it's this portion of the vital capacity. And again, that's the portion that in face of small airway disease, they end up having the scooping out, the reduction in flows over that point in time. Peak flow, easy to measure the status of airways, which is why we use in the ER. It's effort dependent, and this is something we don't really keep in mind a lot with our asthmatics. Those peak flow meters, those disposable plastic peak flow meters, they degrade over time. So if they're starting to see lower values, getting a new meter might be the easiest answer. Because I mean, it's like anything else, it's just going to wear over time. But again, it's easier to pick a peak flow. I mean, what's my peak flow there? How the hell do I know? Peak flow here, oh, it's 5 liters per second. Whole lot easier. And how do I determine liters per minute? How many liters per minute is that? Multiply by 60 to get 300. We talked about when we went through PFTs and maximum voluntary ventilation, have somebody be as rapid and deep as fast as they can and as deep as they can for 12 to 15 seconds, and then extrapolate that over to a minute's period of time. Again, it's very effort dependent. Why do I get this one in there? I know you don't. Well, let's take a look at it, just for giggles. Patients being ventilated in pressure control ventilation. You guys know what that is.
Yes.
You have an exhale tidal, 400. Physician says he wants 450 to 500. What ventilator setting change could you make to allow for a larger tidal volume? I'm sorry? What'd you say?
Increase the eye time.
That's absolutely correct. Why?
Because if you have one, you can get one shot.
How do you know that?
You told me that.
That's not universally true. What about that graph tells me that eye time is the correct answer? Huh?
The volume coming in and volume goes.
Is that baked to baseline? So there's still some additional flow rate that could be pushed into the lungs. Lengthening eye time will make this come back to baseline and get an additional volume out of it. Going further and lengthening eye time further does nothing to increase tidal volume after that point. Once that's back to the baseline, there's no reason to go longer than that. All you're doing at that point then is creating an inspiratory pause. Follow me on that? Okay. Because Mary told me. Please. All right, let's talk about floops, flow volume loops. Remember that by convention, the expiratory loop is always on the top. The inspiratory loop is always on the bottom. Why? Because I can, expiratory is always on top. Inspiratory is always on the bottom. I can derive my peak expiratory flow rate and my peak inspiratory flow rate by looking at the maximal flows that are attained. This distance here is going to be my vital capacity. So if I gave you a graph, you would tell me that this is a 5-liter vital capacity. My peak expiratory flow rate is 600 liters per minute. My inspiratory flow rate looks like it's a little bit above, let's call it 500 liters per minute. This is at 10? 10 times 60. And there's a couple other points that you can look at. Here's my 25%. Here's my 75%. So the slope of this line between those 2 points would be derived as my average flow, what we're going to call the FEF 2575. And then there's a value here, which we haven't really talked about. The FEF 50% and the FIF 50%, we're going to pick on in just a few minutes. Or maybe it's next time. I can't remember where I have it in the lecture. That all pretty much a review? Vaguely. Oh, I do talk about it now. So let's say I had an obstructive defect. Question is, where's the defect? Is it intrathoracic? Is it extrathoracic? Is it a fixed airway obstruction? And I look at the FEF to FIF ratio. I look at the actual flow rates that exist for those two, and I say, is it between 0.8 and 1.0? And again, this is only if I have an obstructive defect to start with. It's just a matter of taking a look. Here my flow was 6. Here my flow is almost a little bit over 8. So if I look at that ratio, 6 over 8 is 0.75. I could suspect something might be going on there. And there's really 3 situations you would have. One, where the expiratory flow is higher than the inspiratory flow. One where the inspiratory flow is greater than the expiratory flow. And one where they're equal. And we're going to find that these are 3 separate scenarios that can exist. So let's, what do you think is going on there? It's a scooped out obstructive defect, right? So normally we talked about previously seeing our normal, our restrictive, where again it's not a flow rate issue, but rather it's a volume issue. This white line is the predicted. Obstructive, we have the scooped out, small airway obstruction, which was typically what we've looked at. Then we need to look at the other 3, which we haven't talked about. Fixed, where the FEF 50 is equal to the FIF 50. In other words, I is equal to E. I have one here where I is greater than E, and E is greater than I. E, I, or E, I. Right? It's the point at which you have 50% of the vital capacity. So here's my vital capacity. What's midway between those points? What is the flow here? What is the flow here? Well, they're about equal. Not quite, but it's a bad picture. All right. Here's an easy way to remember this. I said here that I was bigger than E. The inspiratory flow at 50% of vital capacity was bigger than the expiratory. I is bigger. I for intrathoracic. E is bigger. E is for extrathoracic. And it's just pictures of them again. Okay, so we want to look at multiple flow volume loops. Again, we want to have reproducibility. And we're going to look at these to determine what type of airway obstruction is present. We're going to classify anything where the obstruction is above the suprasternal notch as being extrathoracic. So outside of the thoracic cavity, outside the operculum. Intrathoracic would be below that point, inside the thorax. What? You give me weird looks. Operculum? Operculum is the ring that is created by the thoracic cage at the top, the bony structures. Well, there you go. We learned a new word today. Fixed airway can be either or. Let's talk about the variable extrathoracic first. Children, don't make Dad have to come and stop that bus. What ends up happening with the extrathoracic obstruction is as you take a breath in, you create a negative pressure intrathoracically. However, which means the pressure in the trachea is negative. The pressures in the airways become negative. But because I have a variable obstruction, this negative pressure inside the airway causes that to suck in. On exhalation, where I have a positive pressure forcing that air out, that forced positive pressure is going to bulge that out. So this area where the variable obstruction occurs actually moves more than the other parts of the airway. There's something structurally wrong with the airway that it does not maintain stability. Hold on to that thought. Itch. Got the idea? We're outside the thorax, so the effect of this, of where that movement of the wall occurs, is directly related to, do I have a negative inspiratory effort, a negative pressure created on inspiration, positive pressure created on exhalation. So here I would have an extrathoracic. This flow is higher than this flow. Well, what you would see then is that ratio being greater than 1. What would cause that? These various things. Basically upper airway things. Things related to the vocal cords. In fact, vocal cord paralysis is probably the most common one you'll end up seeing. Okay, so these are extrathoracic. How about that for a little tumor? It's not a tumor, it's a melanoma. Here's my vocal cords. And you can see how much of an obstruction that would end up causing. Not well. I don't know, the picture isn't saying anything. I'm here all week. Try the veal. Intrathoracic, meaning that the inspiratory flow is higher than the expiratory flow. This is going to give us a ratio less than 0.8. And these are things that are associated with stuff inside the thorax. So again, on inspiration, I create a negative pressure. No problems there. But when I forcefully exhale, the airways inside the thorax collapse. When you forcefully exhale, you create a positive pressure inside the chest. It collapses that portion within the thorax. So this is something where we're, again, inside the chest, tracheomalacia. So the lower portion of the trachea is softened. That's inside, just above the carina. It's going to collapse inward. And we're going to see an intrathoracic obstruction. Fixed airway obstruction, it doesn't matter. It's there permanently. And a good example of that would be a goiter. Although tumors can be the cause of it also. Does anybody know what a goiter is? That might be a fixed airway obstruction. Oh my goodness. That's got to be an old picture though. It just looks like an old hairdo. So again, which one is this? Extrathoracic. This one? Goiter. You have this in the back. I believe I blew this portion up. It's a good explanation of it. So if you need some additional reading on it, which I know nobody pays attention to, it's there for you. Can't remember how much more I got going here, but let's just go on. Pre and post bronchodilator. Whenever we have a ratio, no, I meant how much I'm going to cover today. Whenever you see this ratio less than 70%, we automatically should do a post bronchodilator study, because that means that we have an obstructive defect. We want to know whether or not a medication being prescribed will help out. Don't worry about these. I'm not going to ask you anything related to that. But there is, if somebody is on a medication, they should be withheld for a period of time to see if they're, to give this, the study validity. I mean, if you're on a beta agonist and I'm doing a test on you, it's not going to be very accurate. And if they're unable to document, or unable to withhold, just documenting it. And basically, we're going to give them a bronchodilator, wait about 15 minutes, because that's about the time peak effect for most inhaled sympathomimetics. And we look to see if the FEV1 improves. And ATS was what we've used up to this point in time, although there's a little bit of variance between them and the ITS and the ACCP. Do you know what ATS stands for? American Thoracic Society. International Thoracic Society.
American College of Cardiac.
No, not cardiac. Who are we? Chest. If you ever see a physician and he has this after his name, MD, DO, FACCP, that means he's a fellow of the American College of Chest Physicians. He's board certified as a chest physician. That's how you gain that classification. You guys know how physicians get trained, right? They go through medical school, okay, 4 years. They typically do a residency. In the case of a chest physician or a pulmonary physician, it's usually a 3-year residency of internal medicine. Then there's I think a 2-year fellowship in pulmonary medicine, after which, when we back up, after you graduate medical school, you take your medical boards and you become a physician. Then after you complete your internal medicine rotation, you take your internal medicine boards and you become board certified in internal medicine. Then you can go back and take your 2 years of pulmonary fellowship, pass your pulmonary fellowship exam, and become FACCP, a fellow of the American College of Chest. Training. Both have the same. It's just whether you're coming from an osteopathic or an allopathic background. I mean, as far as in this day and age, there really is not a big difference between a DO and an MD. But they both have similar processes to become board certified. Okay, so that 12%, 200 ml. We're going to focus on the FEV1 rather than the FVC. So any problem I would give you would be with the FEV1. And you remember that it's no. Yep. So, here I have my predicted values. Here I have my before and my after, and this is percent predicted. Is that a significant response? What do you got there, Amy? 1.29, I'm sorry, 1.59 minus 1.29 divided by 1.29.
It's
23%? Okay. So looking at this, I would say, well, this went from 34% of predicted to 45% of predicted. Is that significant? And in actuality, it is. So you got to do the calculations to be able to determine it. And is it 200 mLs? Yeah, it's 300 mLs. Oh, 23%. Look at that. So again, not the ratios doesn't seem to have the significant change, but it is there. Nah. Leave that slide alone. I'm not going to go there. There we go.